Thanks, man.
All right. All right. So you got the people in Violent. You guys can see my screen. See?
I can see it.
Okay. All right. So basically later with some pressure volume loops to understand and get a better understanding of how we should approach cardiogenic shock and some of the modalities that we can use. So really this is just kind of an intro into that, as well as some of the devices that we have at our disposal. And then afterwards, you guys can all have my login to the Harvi simulator to kind of play around with it. It has a bunch of interactive lectures and some videos, and it's probably the best thing out there to understand conceptually why certain things would work and certain things won't work. So we're going to start with just a couple of quick slides before we get into it, because the basis of the Harvi simulator is all pressure volume loops. So you start at point A, and you've got like the diastolic filling of the left ventricle. The mitral valve closes. You get the isovolemic contracture of the ventricle, and you get point C, where you're ejecting all of the blood out into, or most of the blood out into the rest of the body. Obviously the aortic valve closes. You get a drop off that pressure. The mitral valve opens, and you get filling again. So in general, you can adjust the pressure volume loop with 3 different ways. One, you can increase the preload. The increase in preload is going to increase theoretically your filling pressures, and should. If you increase the afterload that the ventricle has to compress against or press against, obviously you get a higher contractility of the ventricle, but you end up having a relatively stable stroke volume. It's just augmented in the shape of the overall loop. And then if you increase contractility and you pull that, or you get more stroke volume. So that's in general how this simulator kind of works. So we'll start off with our definitions of cardiogenic shock. Mainly our definitions come based on numbers. Mainly you'll have either your cardiac index is less than 1.8 with or without any sort of medications, or if it's under 2. Wedge is greater than 15. If your power is less than 0.6, or if your PAPI or your pulmonary artery pulsatility index is less than 1. So how we can measure with the Swan-Ganz catheter, or even a really well placed right IJ, the FIC, you need the Swan-Ganz to do a true thermodilutional output and index. You can obviously wedge them to get your wedge pressure, but these are calculations. So power is basically understanding how pressure and flow work. Obviously, your flow is your cardiac output. The pressure that you're looking at is MAP. So pressure is equal to flow times resistance. So that's why, if you can have a normal blood pressure due to really high afterload resistance, which gives you a pressure, but a terrible cardiac output. But that being said, if your MAP is high enough, your cardiac output doesn't necessarily have to be more like robust to give you good end-organ perfusion. So cardiac power is kind of driving home, or how we would measure that concept. There's really no good way to measure how the right ventricle filling pressures and things like that. But for the right ventricle, we don't really have a good measurement for how it kind of functions. And probably the best thing, or the most quoted thing out there, is your pulmonary artery pulsatility index. So basically, when you put a Swan-Ganz catheter in, you're going to get 2 waveforms, and it's going to give you your pulmonary systolic pressure over your pulmonary diastolic pressure. is your delta pressure. And ideally, it should be more than 2 or 3 times whatever your CVP is. So, for instance, you put a catheter in and it reads 25/10. So your delta pressure is 15 and your CVP is reading 6. So 15 divided by 6 is like 2 and change. So your PAPI is at least greater than 2, meaning it's important when we start talking about, when somebody goes from just an isolated ventricular failure to either bi-V failure, and in which case sometimes isolated single like left ventricle support, which we most commonly use and know of, is where it will fail you. So let's go through a couple of cases. All right, so case number 1, we have a 62-year-old guy who comes in with can't lay down flat. He's afebrile. He's obviously hypotensive. He's got an irregular heart rhythm that's pretty tachycardic. He's tachypnic. He's hypoxic. And while this EKG does not show AFib, it also does not show an acute STEMI. And our chest X-ray looks like that. So what would you want to do first?
Can you hear us, Jared?
Yeah.
What are you guys gonna do?
Well, I mean, the metal don't look too good. So I
We-
feel that.
We will do a bedside ultrasound.
You're going to do a bedside.
The vitals look terrible.
I would probably treat his hypertension first.
Okay. So what do you want to do?
I would start him on some Levo. I would put him, supplement his oxygen. I don't know what he's on, but I would put him on at least a non-rebreather or BiPAP. Right here. Yeah.
All right, so we BiPAP him, his SAT comes up, you put him on Levo, and it goes into the 160s, and his BP is better, but it's marginal.
Why don't we try Neo instead?
Sure, it stays the same.
His blood pressure became borderline and heart rate was 160.
It didn't help.
Give you a hint. He's irregular.
He needs to be cardioverted. He's unstable with AFib. If that is AFib, I can't see the EKG very clearly.
Yeah, I mean the EKG doesn't show AFib. It just doesn't show that he's having a STEMI. It should show AFib. I couldn't find a good EKG based on my quick search of finding EKGs. All right, so you want a cardiovert?
I believe so. The audio is
Are you going
in and out,
front and
catching bits and pieces.
Sorry, you're just, Jared, every once in a while, you're kind of coming in and out. It's a little delayed, so we might have to give each other patience on the line. It's hard to
Okay.
hear.
So you want a cardiovert?
Yes.
Yes.
Okay. Where are you putting the pads?
Traditionally, you're taught left chest and left
We're gonna
mid
use our
axilla,
word.
but you can do posterior, anterior, or post anterior and mid axilla as well.
Is one better than the other?
There was a recent study I read on this, and I believed it showed no difference. You use the posterior approach when the mid axilla is refractory, I believe, is what it said.
Right. Yeah, so you're right in that there was a recent study. It was called the EPIC trial, and it showed favorable to anterior and lateral. Almost 20 percentage points better across all shocks. So you shocked him, and now
CVU or CTIC main desk.
hold on 1 second. Jared, I see you. Hey. Yeah. Okay. Okay. Bolus or a leader? Yeah. Yeah. All right. Thanks. Sorry about that. Okay. So now the patient's AFib is gone. Their blood pressure improves, but only a little bit. Now we're like in the like 98/60, and now Awab, we can do your bedside focus shows that.
Severe MR.
Yeah, really bad MR. Okay. All right. All right. So if you were to plot AFib with really bad MR, this is basically what the pressure volume loop. Okay. So we shocked and we patient out of AFib. So now it should just look like this. So if you're looking, you'll notice that you have a very robust blood pressure, right? Like 140/80. But if you come down, your cardiac output is low, only 2.3. This is wrong. Your wedge pressure is probably going to be much higher than this. But I couldn't find a way to game the system to get it to look correctly, okay? You BiPAP'd them. I think somebody said that they would put them on Levophed because they were hypotensive. So what happens if you put this patient on Levophed? So their map, right? We're 133/101. Our map is in 90. Our output dropped, cut in half. Right. So I know that we're always, or most of us have been taught that Levophed is your first line treatment. Okay. So what are the basic principles of management of acute MR? What do you have to do?
Decrease afterload.
This is probably more right. This is a decrease afterload, right? So when we put them on Levophed, did we decrease afterload or increase afterload?
Increase.
Right.
We try Melerdone or Debutamy.
Could, absolutely can. We'll stick with the pharmacology then. All right, so we put them on dobutamine. We put them on a hefty dose of dobutamine. Let's say we put them on 5. Our pressure stayed the same and our output is better than what it was on Levo and slightly better than what it was unaugmented, but overall didn't really change, correct? So what modalities commonly been used as an afterload reduction aside from pharmacology?
Can you repeat that?
I said BiPAP will help reduce some afterload.
Yeah, BiPAP definitely will, and we can even put them on a good solid dose of nitro too, right?
So if you start nitroglycerin on that patient with a, pressure of 50 over, and yeah, I get that wrong. I see it.
I think that was reflecting on how, there might be an ideal scenario of what you would like to do, but what she's concerned about is the result of hypotension.
Would you?
Absolutely. Absolutely. That's why I showed that nitro makes everything worse.
Yeah. So in theory.
In theory, it should work, but nitro made everything worse, and that's the beauty. We can work through it mentally, and all we do is change a loop as opposed to kill a patient. So you BiPAP them. We've shown that we can't nitro them. We've got them on a pretty solid dose of dobutamine. Our output is still low, even though our blood pressure is okay.
Would you
ABIM general, everything is at your disposal.
I didn't have no cost of friends.
I didn't catch that.
On the blunting on the angles, would diuresis help?
Yeah, so we can do diuresis. Let's see. Sorry. All right. So you want to give diuresis, right?
Yes.
So we diuresed them 1 liter. You gave them 2 and 5 of metolazone, like a good intensivist, and you diuresed them.
To make it stop. Oh no. Okay.
Give it back.
So
Give
we
it back.
need we need a preload,
What about
right? We need a good
Impella?
stroke diagram. Or that.
Yeah.
Or
So let's say at first you're at the ABIM general, and they say, well, how about we try a balloon pump first? All right. So we try a balloon pump. We're augmenting 1-to-1. We've got a pretty good volume within the balloon. It should theoretically increase or decrease our afterload. And if you Google or do a PubMed search for acute MR, the most common device that you're going to see quoted out there is the use of a balloon pump. Most people will still quote it as one of the primary uses for an intra-aortic balloon pump. But did our cardiac output change?
No.
No. All right. So I think Lindsay had asked for. Right, she'd asked for an Impella. So let's say we call this same.
Go
We call
ahead.
it different. We call it different interventionalist. We call it different interventionalist. Maybe a younger one who is agreeable to swap out our balloon pump for our CP Impella.
Longer rely on the measured output anymore.
So, yeah, and the pressure volume loop will change too. But notice that we are able to get a better output. We're up at 3. A CP Impella is only going to give you maximum 3.5 liters of flow. So that's going to settle you out at. And so let's say even though if you put somebody on, VA ECMO, peripherally, peripheral bypass at this point, is the VA ECMO going to increase or decrease the afterload that your ventricle is pumping against? It's going to increase it. So if you had jumped straight VA ECMO in this patient, and we went, our drainage is from the right atrium and our return is into the femoral artery, and we turn up our flow, we will definitely improve our cardiac output. You're right, you'll lose whatever you're losing, but the VAD will give you, right? But your wedge remain the same. That theoretically, you're increasing the afterload, you'll be draining out of the right atrium, and you're shooting it back up the aorta. The ventricle is going to have to now pump against a higher afterload, and in essence, will most definitely worsen the MR. So then, what if you put them on VA and used an Impella at low speeds just to vent the ventricle? Now we went from 4 liters of flow with VA ECMO up with just venting. Now we can get a decent, true good cardiac output that should be okay. Lower our wedge pressure at the same time. And I'm highlighting this case because when you have acute MR, no medicine is going to fix it. And you have to do a lot of fancy stuff with the devices to get them in an ideal scenario. But ultimately, this becomes a surgical emergency. Importance of our use of point of care ultrasound. So when you look at MR, there's primary MR, mainly from endocarditis, a muscle rupture, some sort of trauma, or just a cord rupture. There's secondary MR, which is basically you have a chain that causes the dilation of the left ventricle that alters the mitral valve. And then you can have some sort of stressor or acute decompensation on a chronic MR. So maybe this patient had chronic MR, went into AFib, and got themselves into a lot of bad trouble. The answering to how the mitral valve works, absolutely no idea after reading this a bunch, has to explain the overall complexity of the valve, other than to say as there's multiple strings holding the thing together. There's a ring. There's 3 different leaflets. They all have to match up perfectly. And if you change the ring, the cords, or the leaflet, you can be get in really bad trouble. Or for MR, if they're warm but they're wet, then you can just get away with afterload reduction, and avoiding tachycardia. Because remember, these people are ejecting back most of their volume. The slower or longer filling time that you give them, the more they're going to be able to eject some back and some out. That's when you really need support, and you're going to have to defend your coronary perfusion pressure. So volume in general should be avoided, but targeting this overall euvolemia is going to be really hard. But you absolutely cannot let them have any sort of afterload. And almost always, this is a surgical emergency.
Yeah, just to recap that, Jared, because there's, I know we don't want to keep it unmuted, just there's a little side conversation here, but just to reiterate, you mentioned particularly for VA, why there was some question about why that would increase afterload. And I think it's important to note that what we're referring to as peripheral cannulation for VA. So meaning that that is always going to be retrograde flow.
Oh,
So that is by nature it's going to be increasing it essentially. And then you're talking about, just so because that was just one question here. And then just, I'm sure everyone else is thinking the same thing. So we're all on the same page. And then the reason why it's really difficult when you went through all of each of the changes with the pressure volume loops, the reason why nothing was really improving this is that to drive home that this is a structural problem and therefore it is a surgical emergency. And so there's ways that you could make this worse by choosing the wrong therapies. But ultimately it's an immediate surgical referral. This is a surgical process. And there's a couple of things you can do to temporize these patients. And that's really just to drive home what you're emphasizing. Because I think there's just a little confusion about that part. So there's a lot of things you can do to make this worse. And what you want to do is, number one, recognize this as a surgical emergency and do a couple of things you can do that can link them along to get them to an optimized place for surgery. But this is like one of the hyperacute indications.
Yeah, I likened acute MR to aortic dissection. This is straight to surgery.
I think that's it's easy to present this and have it feel like a medical case, but that's the important part, is that this is recognizing that acute MR is a structural emergency. You're going to immediately call a cardiac surgeon while you're stabilizing this patient, avoid some of these pearls and pitfalls that Dr. Ward's going through. And then generally speaking, most of your surgeons are going to want a balloon pump immediately, and they're going to want this patient optimized for the OR as much as you can. It is extraordinarily high risk of death. So that stabilization comes with a lot of the pitfalls that they're referring to. They're just really difficult to manage. I would argue the most difficult to manage. So yeah, all these loops are really important to be aware of, because essentially a lot of the things that we would normally go to do would make these patients worse.
Now, you're saying that they would normally last for the balloon pump, right? But I mean, if you were able to argue for an impella with cardiology, do you think that would find a better time?
I mean, that's going to be up to your surgeon. You're definitely going to have this discussion with and again, these are patients who they can.
Yeah, that's what I'm just wondering, at least with impella, you'll at least have appropriate forward flow, I guess getting here too.
Yeah, there's other reasons that
Just to piggyback.
Yeah.
Just to piggyback off of Lindsay, overall acute MR, let's say they're not in shock for some reason. The overall, what I was reading on this was the mortality range between 6 and 24% intraoperatively. If they are in cardiogenic shock, it can be upwards of 80%. So these are they will try to get them better, or even if the question would be sometimes even if they're a good surgical candidate, because you can use mitral clips, but that's a whole other discussion. But you ask about, so we'll go over balloon pumps, because I want to go over the waveforms, because in general, this is where your critical care board questions are going to come from. You're going to have inflation filling. Sometimes you'll see an inflection point up, which is an overshoot. So the balloon pressure goes up, it plateaus while the balloon is kind of holding there, and then it deflates, and then it returns back to its filling baseline pressure. So you should see this waveform on the balloon pump. It should be the bottom waveform, and then the top waveform will be your arterial waveform. So remember that when the is inflating in, then it deflates during systole, so that your heart's not pumping against an inflated balloon. So notice that you have an adjusted end diastolic pressure, which is lower, which is where they'll say that it decreased the afterload. Pressure from the balloon pump. So the way you're going to get your waveforms on the critical care, they'll show you this, or then they're going to show you this, right? So this would be an example of too early diastolic filling, which is basically you didn't give the chamber enough time to fully empty, which can be an increase in overall afterload. There can be a delay where the balloon isn't going. The balloon pump absolutely useless because it's not helping achieve the backward pressure. If it dumps too early and that it deflates too early, this is mainly where you're not perfusing those coronaries to the best of the balloon pump's ability. And then if it delays too long, you'll see that it actually the baseline dice. It allowed for, it inhibits full emptying. So you're decreasing your coronary perfusion pressure. So those are going to be the common waveforms that you're going to come across on your board exam. So you ask about the impella.
Hey, Jared.
So yeah.
Quick question, in regards to the balloon pump, just to make sure I understand. Afterload, how is that affected by the balloon pump? Does it decrease the afterload by creating like a vacuum, or is it concerned that it might increase afterload? I saw the graph is showing that if timing's off, it can either worsen or help.
Yeah. So most of the balloon pumps now are automated. So it's really hard to change when the balloon is augmented. The newer ones, it's all automated. So theoretically, when the balloon is in full distension, it's going to press against the walls of the aorta, and when the balloon deflates, it quote unquote creates a slight suction event where your aortic is slightly more compliant, so you don't have to have the same pressure. So that's where the perfectly timed balloon pump will decrease the afterload that you're pumping against. And that's why it will quote unquote give you anywhere between 0.5 up to maybe at maximum 1 of an increase in your cardiac output.
Gotcha. Thank you.
No problem. So, Alok, you ask about the impella. They're going to come with the impella could work in these circumstances, but you're probably going to have some sort of flailed leaflet, and the geometry of your ventricle isn't going to be normal. It may be dilated or it may be normal, but remember, of least resistance. And in acute failure or even chronic failure, the left atrium is always going to be less of a pressure than the aorta. So when you put the impella in, most of the volume is actually going to be moving into the left atrium and is not going to be setting in the ventricle. So you've got a flailed leaflet somewhere, and most of the flow to the left atrium and back into the lungs. So your filling pressure of your ventricle is going to be somewhat lower. and in general, these are going to come with really high likelihood of suction events for the impella, and it's going to have to be perfectly placed, and you're likely not going to be able to have high P levels of flow with the impella, so you're going to be lower, meaning that the impella, but it's probably not going to be able to give you the 3 liters or 3.5 liters of flow if it under optimal conditions. Did that make sense?
I think so, yes, because then if a lot of blood going back with the MR, there's not enough blood in the left ventricle to actually pump out into the aorta.
The chamber geometry is changed, and that leaflet may cause some problems in obstructing getting the actual impella into position.
Okay, that makes sense.
And then the portions of the leaflets or whatever's like damaged can actually get caught in the device. So, yeah, so it can, because of not only the geometry that changes, particularly the leaflet, but also the actual leaflet
And then-
itself flowing back in can be.
Yeah, and then we kind of, I think Dr. Gillespie already touched on why there are pearls and pitfalls with traditional peripheral VA ECMO. All right. All right. I think we beat that one up a little bit. So next case. So you got a 50. He's got high blood pressure, diabetes, hyperlipidemia. He's got all of his merit badges. He comes in with a 1-day worsening substernal chest pain that goes to his arm and shoulder. He's diaphoretic. He's hypotensive. He's a little bit hypoxic. So what would you like to do?
EKG.
Okay. For EKG, STEMI, not STEMI. STEMI. All right, got elevations and we have reciprocal changes. So STEMI. So he goes to catheterization. So what does that show? I know that we're not cardiologists, but this is where when you guys go to the cath lab for all these STEMI activations, you should pay attention to the screen when they're doing the cath.
It's still LAD?
Yeah, it's definitely an LAD. All right. This literally worked an hour ago. All right. So what you're going to see there is a heart that no mueve. It does not move. So what would we like to do? Oh. No, it's not going to do it. All right. All right. So on the echo, the left ventricle wasn't moving, and our pressure is soft, and if that patient presented to the emergency department, what is the ER most likely going to do?
Levo.
If you're at a rapid and this happens, what are you most likely to do?
Then depending on their mentation and start pressors, and then depending on clinical picture, potentially intubate.
So what happened when we put them on levo? Yeah, our pressure got better, but our output got worse, a lot worse. And our stroke volume is not very good. So what can you do?
I mean, oh wait, they already they still need to be catheterized.
Yeah, but let's say we're working on this. Interventional is coming in and you're working your way to the cath lab, but the patient doesn't look so good, and so you're not willing to put them in an elevator and roll them to the cath lab just yet.
How not good? Are they still talking to me?
And you could say can you hear me?
No.
What'd you say? Can you repeat it?
I said the cath lab's coming in, but you're on the floor or you're in the ER and you don't feel like leaving a monitored setting to get them to the cath lab because the interventionalist is driving in, but he's not there yet. I mean, at this point, you could say, look, my blood, let's roll to the cath lab.
In this scenario, do we have a SWAN in place already? Like, do we know that the output's
Sure.
poor?
You threw it in fast as anything.
Nice job, Alok.
Maybe some Milrinone.
So let's put them on a starting dose of Milrinone. We'd never started the levofed. So our pressure got a little bit worse, which is to be expected when you're starting Milrinone or dobutamine, but our output got better. So let's say you go down to the cath lab, they get they stent they're revascularized, but they're still like this, despite being on some Milrinone, and let's say we'll put them on a little bit of levofed just to make their blood pressure a little bit better. So what would you do?
You know that.
I looked at LVAD.
So you're yeah. So all right. So we're
Yeah,
We're gonna-
still poor.
we're gonna ask them to put in our CP Impella. So why did the pressure volume loop change? Why did it go from a square to a triangle?
We don't have the, what is it, when the aortic valve closure is not gonna matter. So that's why, like, it's not gonna be squared because it's constant output.
Correct. So is that enough? Are we satisfied? We've stabilized the patient?
We still need more output. I mean, we could, the Milrinone's still going.
What if you have somebody that's, yeah, the Milrinone's still going. What if somebody had said, look, this patient's cardiogenic shock, we cath them and we revascularize them, and why not just go ahead and why not just put them on VA ECMO peripherally?
I mean, if we do it with the Impella in,
No, let's say, because people will do this. They come in shock, they get stented, they're hypotensive, their LV EDP is high, and there's somebody in the room that says we should put an Impella in, and then there's somebody else in the room that says we should just put them on VA ECMO. They're cardiogenic shock. We should just put them on
I mean, we're still gonna.
medications. Their output and index are low.
will still end up causing like the myocardium still has to work even harder against that afterload. So if we did peripheral, I don't know how benefit it would be to the heart. Like,
Correct.
think
I
you-
mean,
like, about
yeah,
1%.
look at our pressure volume loop.
He's dead right now.
I don't even know what to do with that for sure.
There's zero cardiac output.
What if you did both?
Yeah, should we opt for central vehicle?
Yeah, nobody's going to crack a chest in this instance. They're either going to put it in peripherally or they're not going to put it in at all.
About to kill him again.
So the answer I think, Alok, was what you were saying is that it is some form of most likely either straight to Impella plus something else to give them everything that you need, or just an isolated like just increasing the support. But
Say it again.
acute left ventricular MI shock.
Can you repeat that?
The answer is the answer is an acute MI left ventricular failure shock. The answer is not just put them on VA ECMO. For all the reasons I think that we previously stated, but can clearly be shown on a pressure volume. There we go. I knew something was wrong. But look, I mean, when you look at what we've gotten with some flow from a VA circuit, plus something to decompress the left ventricle, we get a very robust output with a low wedge pressure. So this is your ideal scenario with just an Impella alone, if you're able to get high enough flow speeds. But sometimes that's not the case. But the answer is not straight peripheral VA. Any questions about that? All right, so we're gonna play the Impella game. Okay. So they come in a couple of different flavors. There's the 2.5, the CP, the RP is right-sided. Those are all the percutaneous ones. Then you come in with the go subclavian in or grafted straight onto the aorta. The 5 doesn't exist anymore. Now it's a 5.5. Most people don't use the LD. So what are our contraindications to a Impella?
Aortic regurg.
Dissection.
That's it. There's only 2 contraindications.
I guess like if they're already having like PIC or any like lysing of red blood cells.
No access point due to like infection cellulitis.
Lack of access. Yeah. So I always think of these about the contraindications. I think distal to proximal. So bad peripheral arterial or some sort of aneurysm, something wrong with the aorta. If they have a mechanical valve, you obviously can't put it through a mechanical valve. If they've got an incompetent aortic valve with either really bad calcified deficiency, if they have a clot in, you're not going to suck clot out and blow it out to the rest of their body and have them stroke out. And if they have any sort of left to right or right to left ventricular defect or shunt, you also can't use it because the concern is that you'll put it through from one side to the other. So with the, I don't think this what our contraindications are. All right. So when you're looking at impella, one more, say that again.
Is that just for like severe aortic stenosis or like any level?
It's mainly if the area is too tight to get the actual impella through, then you can't place it.
Got it.
All right. So groin, and then they're going to wheel this fancy, machine in, and then this is going to be the waveform that you see. So there's a couple of different things. There's our placement signal in red. There's our motor current, which is, how the current is going to be, our amplitude. And then you're going to see, your flow down here. So this is a CP impella because we see it's 3.5 liters of flow. Control screens here on the right. The important thing is to pay attention to the two signals, okay? You guys, because Inspira puts in impellas, you guys can go on to the Abiomed Academy and just use and create a general login and click Inspira, and you can get access to all of the impella training videos. I'll send the information out after the lecture along with the Harvi login, but of impellas that you guys should review. All right, so what does that look like? Is that normal or abnormal?
Abnormal.
Abnormal.
All right, so what's wrong with it?
There's no flow.
All right, so there's no placement signal, right? It's very dampened or flattened. A flow. And this is important because you have no idea where this thing is. It's either fully in or fully out, but it's very much not in place. So anytime you're going to touch or move it, one, you have to do it under ultrasound guidance, and two, you always drop the P level to 2 before moving it. Okay? But that's basically, and that's what you see on the impella flow, then it's either too far in or too far out, but it's not where it should be. Normal or abnormal?
What's abnormal? Yeah.
All right, what are you seeing? What are you noticing? Is it the placement signal or the motor current?
Placement signal.
Right. All right. So it's the placement signal. So placement signals should never have a negative number. They should always be positive. So if you see something with a negative number, inflow and outflow are setting on probably the same side as of the aortic valve. So this is the instance where it's too deep. So this is when you're going to look under ultrasound, look at it, confirm it. You can put color flow on it, and I'll show you what one of those that color flow looks like. But this is where. All right. Normal or abnormal?
Abnormal.
Which one's abnormal?
The motor.
The motor is the placement signal normal?
Not really.
It has some pulsatility to it, but it So this is what they'll call a dampened signal. There's some signal there. The numbers are about right, but everything appears to be low. And the answer to this is you don't exactly know where the impella is, but it could just be that you have low that there might not be a sufficient pressure difference across the aortic valve for the impella to sense. So sometimes you'll see the impella goes in, the blood pressure, on your A line, your systolic and diastolic are the gap is very narrow, and they won't have, or they'll have very minimal pulsatility on the impella. To see if sometimes you may need to augment their cardiac output with meds, that the device just isn't enough. But you also really need to confirm the position of the impella. So if the impella is in good condition and you see this dampened or low pulsatility waveform, then it just means that they have very low underlying cardiac function. So confirm the placement over this. Okay. And so last one, normal or abnormal?
I don't know.
What's off?
Is it the amplitude of the placement signal?
No, that's got good pulsatility.
The placement signal is irregular though.
Yeah, but this is what it looks like when it's normal.
An issue with the motor or not? An issue with the motor then?
So it could be you need to definitely check for typically if purge alarm, mainly because there's something wrong with the purge fluid but that'll go off. But this is when the motor flow drops, your placement signal has pulsatility to it, but it's lower. This is when it's going to give you the most common alarm that you're going to see, which is going to be a suction event. And the answer to this is a couple of different things. Is sometimes incorrectly positioned. Sometimes you may have inadequate filling pressures, or sometimes the RV has failed. So whenever you get a suction event, realize that you're just basically trying to suck up a dried well. And so whatever's going to happen is you're going to shear the red blood cells. So you're going to get a lot of hemolysis if you just let the thing keep suctioning and alarming. So the answer is your speed. So this one is at P8, which is the highest setting an impella can go. So you should drop it to maybe 7. If that doesn't work, 6. And then reconfirm the position under echo of the impella, and then look at your filling pressures. So at these points, you should almost always have a Swan-Ganz catheter and look at your filling pressure. If the filling pressure is low and your CVP is like 5 or something like that, okay. Ideally, I think if you talk to the impella reps, they want to see a CVP of around between 10 or 12 whenever the impellas are in. So let's say you have this alarm, your CVP is 14 or 15. This is when, if it's in correct position and your CVP pressures are high, this is when you need to also think about that the patient has into biventricular failure and that their right side has failed as well. So you should see this on an ultrasound, that you'll just see the RV dilate out.
Can you repeat that last part? You cut out for like 10 seconds.
Okay, I was saying that if the CVP is high, you confirm the position of the impella with ultrasound, and it's still giving you this suction event, the bedside echo should failed. You went from isolated left ventricular failure to bi-V failure. this is where making sure you're always watching the PAPI comes into play, because you will see a downtrend in your PAPI probably before you start to see the suction alarm on the impella. I'll show you a couple of images, and I want you to tell me if you think it's in position or not. So when you put the ultrasound on in the long axis, this is what you're going to see. You'll see a catheter tip. You'll see something. Normally with the CPs, you'll see the pigtail come off of it. So do we think it's in position or not?
Not in position.
Is it too far in or too far out?
Too far out.
Too far in?
Yeah, so you can see here, I think this is kind of hard to see. The impella is going to have a pigtail, the inlet area. You should see some sort of lucency in the actual device, which is where your inflow valve, the inflow area is, and then you'll see the valve. So when you're looking at it, you'll see you'll see some sort of teardrop, or sometimes you can trace the pigtail back. You'll see an area of lucency in the actual valve in position. But if you ever see mixing of color, showing backflow against the ultrasound, it's in general both. It's basically you're pulling in and shooting out against the aortic valve, indicating that it's too far in. Let's give you 3.5 liters of flow. They also need to be 3.5 centimeters off the aortic valve. So when you measure the inlet area and the aortic valve, they need to match up at it needs to be about 3.5 centimeters. So 3.5 with CP impellas are the magical number, okay? One more case, but it's a little bit, it's mainly going over more of RV failure stuff. I know that there's still some other lecture to go today, so I'd like to field some questions, or at least clear up as much as we can, and then maybe we'll pick the other one up another time and we'll come back to this.
What was the thing with the biventricular failure? You were cutting out like a few slides ago.
I have one more case, but we've already kind of crossed the time. I think Alok still has to lecture, so we can stop here and we can answer as many questions as we have, and I can pick it up. I can pick the other case up another time.
Yeah, I was asking with like this previous case that you were talking about. You were saying that the patient that got into like biventricular failure. Could you go through that again, because you were cutting out? So I didn't catch all of it.
About the impella?
Yeah.
Yeah, so if your impellas are going to suction because they're either malpositioned or they don't have good filling pressure, most commonly. If though your CVP is high, the impella's in position and you're getting suction events, it's because the right ventricle isn't passing off to the left ventricle. You would see a drop in your PAPI, or your pulmonary artery pulsatility index, which is why it's important to look at those numbers as well as your cardiac output, because you don't want the RV to fail on you when you're will change most likely before you start getting these suction alarms. You're going to see it downtrend before it fails.
Okay.
And Jared, when we're looking at the PAPI on this one to look for biventricular failure, don't we have a higher threshold to call it right-sided heart failure?
Yeah, because theoretically the impella should be offloading, so
Yeah.
it can't be, it is finicky.
CVU or CTIC main
Oh,
desk.
hold on one second, guys. Hey, it's Jared. Hey. Just get 40 PA down. Thanks. So the RV is finicky. It can fail for that it got overdistended and failed. Sometimes they may have residual disease that the cardiologist didn't feel like stenting and it failed. Sometimes it can just be the overall, that they dropped their blood pressure, their left ventricle got dilated, they got backflow into their right ventricle, they dropped their coronary perfusion pressure, and the to get them a perfusing pressure, but in the interim, we crushed the RV. It's generally some mix of multiple different things of why the RV fails. And I've got a lecture coming up sometime this year where we'll really delve into RV failure.
Okay, cool. Thank you.
All right.
Thank you, Jared.
All right, if you guys, so I'll send an email out with the Harvi login so that you guys can use the program and screen for the Abiomed Academy so that you guys can go through the Impella videos.
Perfect.
Awesome. All right, thanks guys. If you ever need anything, just let me know.
Cool, man. Thank you for your time.
Thank you.
Thanks, Jared.
Yeah, who said that?